called the aging foot, and you guys know on a regular basis that some of the toughest people to fit and some of the questions we get from our older patients can be a little bit challenging. So just want to give you a little background on how to fit the foot. And like I said, a lot of this is based on my book, which we'll be updating here shortly. I'll start with a little riddle, the riddle of the Sphinx. This is based on Greek mythology. The riddle is, which creature walks on 4 legs in the morning, 2 legs in the afternoon, and 3 legs in the evening? Has anyone heard this riddle before or know the answer? The answer is man. We walk on 4 as a baby. In the noon of our life, we walk on 2. And as we age, we use a cane, so we walk on 3. I like that riddle because it really does kind of speak to the evolution of humans and how we change and how our gait changes as we age. Foot conditions are very common as we age. That probably doesn't surprise you guys. Symptoms are among the top 20 reasons for physician visits for people aged 65 to 74. And this study from Italy in 2003 showed that less than 3% of people aged 60 and older had what would be considered normal feet. That's a broad definition, but I think it's interesting. What's important, and I think what you guys appreciate, is that foot pain negatively affects our overall health and well-being. And that's part of the reason that people come in here, right? A lot of people will have a very specific reason that they need a new shoe or a problem they had with a previous shoe. And there's things we can do to help them. But even simple things like doing activities of daily living around the house can be negatively affected by pain. And then this is one thing that I don't think a lot of us appreciate. In fact, I didn't even until I started reading some of this literature, that losing the ability to walk leads to a decreased self-esteem, a loss of independence, and social isolation, as well as a lower quality of life. I think that more than anything underscores how important it is what you guys do every day here in the store. Daily steps, I think a lot of you guys are familiar, but most people, I tell my patients, most people take between 5,000 and 10,000 steps a day. All right, and every single one of those steps affects their health. And you can add those steps up to pretty high numbers over the course of months, weeks, and years. Gait changes as we age. Sometimes that's obvious, sometimes it's not, but we do slow down as we start to get older, and part of it has to do with the aging process. Muscles, bones, nerves are functioning differently, but also other pathologic conditions that we tend to develop as we get older. Osteoarthritis affects how we move. Our joints are stiffer, maybe they cause pain, and even our balance changes and decreases as well. There's cognitive, musculoskeletal, degenerative changes. We call those age-related changes. We can't escape them. They're a part of the aging process. And some of the changes that we see are ways that we compensate. In fact, a very simple way that a lot of people will alter their gait because of balance is they'll walk with a wider base of gait. That's one simple thing that I'm sure you guys have observed periodically. Slower walking, shorter strides. You guys have probably seen too, and I'll see this in clinic, some of our older patients will come in, they'll have pain on the bottom of their foot, but they don't like cushioned shoes because they're worried they'll fall down in them. So basically they're choosing to have more foot pain because they're more worried about falling. Some people have to make a tough choice that way. But that's a tricky thing to treat. We don't know the right or perfect amount of cushioning for any given person, but there's little clues we can pick up on as we talk to them and try to help them. I won't go into too much more detail about changes with age, but those are kind of the big ones. And like we mentioned, footwear affects our health. So I've quoted this study a few times. It's definitely in the book, and some of you that have heard me talk before, but 80% of women report significant pain while wearing shoes. And probably because women are more concerned about fashion. Now, this isn't a sexist statement. There's research that backs this up, but women definitely make different choices as far as footwear. The average patient in the study that was done by the Orthopedic Society showed that females were wearing shoes that were 1/2 to 1 inch smaller than the width of their foot and 1/2 to a full size too short. This was a patient that I had to take this picture to convince her that her foot was not shaped like her shoe. I had told her to get a wider shoe, and she came back and said, I got a wider shoe and my foot still hurts. This was her wider shoe. So it was wider than she was in, but it still wasn't a healthy foot to obviously help protect something like a bunion, which we know is very common. Patients that did not have foot pain tended to also wear shoes that were too small, but just not as significantly small. And that can pose a difficult problem when you're on the floor talking to someone. And I know this from personal experience. When I'm trying to tell someone, you probably need to go up a 1/2 a size, and they'll say, no, I'm a 7. I'm a true size 7. I don't wear a size 7.5. Well, you guys have had that argument, I know, before. It's easier for me to convince them because a lot of times they're seeing me in the office, but the best recommendation I can say is that, if you have a specific foot pain or foot problem, and you guys have done this, at least try the next size up and see. A 1/2 a size is only a 1/6 of an inch. A full size is a 1/3 of an inch, so it's not a profound amount of room. Is there a question?
They said bunions are part hereditary,
Mhm.
but is there a part of the bunion that can actually get it calcify or grow more from shoes being too small, too tight?
Well, there's more of an involved question to that, but bunions are progressive, so they tend to get bigger. They tend to become more painful if the shoe is tight. So the 3 non-surgical things to do to treat a bunion is to make sure the shoe is wider, to use a toe spacer between the first and second toe to kind of spread it a little bit, and then some people get some relief from using an arch support too. So those 3 things I tell all my patients, even if they want to have surgery today, I say first start with those 3 things. If you still have pain, then we can talk about surgery.
And will the metatarsal pad pull that bunion, push that bunion?
No.
They won't.
Nope.
Okay.
And nothing will reverse a bunion. So even when you do those things, you haven't changed or reversed it. You're just kind of controlling some of the forces that typically cause pain. There's nothing therapeutic about a metatarsal pad in terms of a bunion, except that as a bunion develops, I can go back to, well, as a bunion develops, it does tend to change how forces are distributed across the forefoot. So from a comfort perspective, a lot of people tend to like a bunion or a metatarsal pad. So of the deformities we tend to see in women's feet, bunions, hammer toes, bunionettes, which is a little bunion on the side of the toe, and prominent metatarsals. So not only do we get toe deformities, but we can get some atrophy of the fat pad on the bottom of the foot, so there's less cushioning there. Sue Grafton, if high heels were so great, then men would be wearing them too. And with a high heel, you can increase forefoot weight bearing by 70 to 90%. So again, kind of a tricky issue to discuss sometimes with our patients, but if they're complaining of forefoot pain and they insist in being in a high heel shoe, I just say, you're going to pick the shoe that you want, but just keep in mind there's nothing magic I can do to help that foot unload your forefoot when you're raising the heel. And common complaints that we see, you guys are familiar with all these. You don't necessarily see a lot of the nail and skin issues, but those are very significant problems, men and women. Swelling is an issue. That, of course, makes it trickier to fit a shoe. Bunions and arthritis. Most of us develop arthritis as we get older. 90% of us will have arthritis in our knees by the age of 70. Similar things in the feet, not just to the big toe joint, which is the second most common of osteoarthritis, common site of osteoarthritis, but also to the midfoot area. And the foot changes too in shape, so it's going to lengthen, it's going to widen. The nails and skin are less resistant to pressure and friction, and so sometimes that makes people more prone to either dryness or calluses. Tendons and ligaments lose elasticity, so basically we become stiffer and less elastic as we age. And that can be part of why some patients will say, geez, I've been in the shoe for years and now it's not very comfortable anymore. Well, it's probably because their foot has changed enough and some of these aging changes have occurred that are the difference, not necessarily the shoe. And foot shape changes, again, widening and flattening. This is very common, right? You guys have probably seen this. This is dry skin, dry nails, a little bit of a bunion, and contracted toes. That's where these extra depth shoes come in handy that you guys are familiar with. On the bottom of the foot, this is hard to see probably from there, but there's a callus here, a callus there, bunions here and here. This is a patient where you'd want to do something to kind of cushion that foot, distribute that pressure, to accommodate the width here, but also accommodate the depth of their contracted toes. That's a challenge, right? There aren't a ton of shoes, and if it's someone who's going to be more fashion conscious, you know that you're going to kind of gently try to steer them towards something a little bit healthier. But in some ways, and this is what I think is important, when you understand these things, it makes it easier to convince them that you have an idea of what to show them. Not like you want to go in great detail telling them about why they have the contractures, why they have atrophy of their fat pad, or why they're having pain, but having an understanding of those changes will kind of help them gain confidence in your knowledge and expertise and maybe accept that they have to change their perspective on what might work well for them. Hammer toes basically start out as a little muscle contracture. The flexor tendons on the bottom are balanced with the extensor tendons on top. So if the flexors start to gain a mechanical advantage, and this happens very gradually over years and decades, right? This doesn't occur overnight, although some of our patients think it does. But those toes will start to contract to the point where they get into kind of a fixed position where they stay relatively rigid. The depth of the shoe pressing on the top, most people start to become symptomatic on the top of that toe where it gets rubbed by the shoe. So sometimes padding that or finding a softer leather or a deeper toe box helps. They can also get pain on the bottom of the forefoot because of some of the pressure that occurs when the toes aren't bearing weight properly. Yes?
How much of an issue do you think one of the guys who used to work here always was worried about when we add in an insole that we're pushing that foot up against the top of the foot and causing issues by that. And
Yeah.
therefore, I think we get a little hesitant, about adding an insole to a free time or something like that.
Yeah. There's definitely a concern about taking up more space in the shoe, right? When they already are probably maxing it out a little bit. Yeah, so sometimes you have to be a little bit creative in terms of either balancing out the thickness of the insole or balancing out the depth of the toe box. Using maybe a lower profile insole. I know you guys like using tacos a lot. Those are great because they don't take up a lot of volume in the forefoot. It can fit underneath an existing insole, but that's definitely one of the considerations. And there's no easy way to predict how much space you can take up. It's still the principles you already use for trial and error about how it feels to them. But I do think with this, like in clinic, a lot of times I do use gel sleeves for my patients. So those little tubes that slip over the toes, those work nicely because they cushion the area that gets pressure, but they can also, if the toe is still flexible, help kind of push it down into a little bit straighter position. I'll tell my patients that maybe a toe sleeve with some of your shoes, maybe you don't need it with all of them. But I kind of look at most of these things as tools. So trying to give our customers, our patients, the right tools and let them use them as they need to stay comfortable and stay active. And the bunion again. So I had to show a patient, the width of her foot versus the width of her shoe. That's not a bad shoe. It's got a stretchy upper. That was better than what she had before. And then just the way that these occur. So bunions occur at a rate of 9-to-1 female to male. So men don't get bunions at the same rate. It probably has a little bit to do with the shoes that we wear, but it also has to do with hormonal fluctuations that females go through and men don't. And that can affect elasticity of soft tissue like ligaments and tendons. But it starts out as a muscle imbalance and gradually progresses. And there aren't any studies that show you can stop the progression of a bunion by doing non-surgical things. But theoretically, if we manage it by doing the things we talked about, the toe spacers, the wider shoes, and an arch support, you're controlling the forces that caused a bunion. And for a lot of people, that does relieve symptoms and may slow down the progression of the deformity. Yes?
How do you feel about the brace or the spacer that people wear overnight?
Yeah, my thought on that is that the forces that cause a bunion are only active during weight bearing. So I'm not convinced that splinting it at night does a lot. The other argument kind of relates to footsteps. If you take 10,000 footsteps a day, and on every single one of those, the toe gets kind of pushed over into this bunion deformity, how long or how often and how hard do you have to try to splint it at night to overcome that? I've never seen a study that shows those night splints work well. I've never seen too many people that tolerated them well. Once in a while I'll get a patient, and by once in a while I mean once every 5 years, I'll get a patient that comes in and says they use them and feels like it helps. If someone likes and uses something like that, I don't tell them to stop, but I also don't really have a lot of faith that those are as helpful as the other things. And part of the reason I say that is there's good research to support the toe spacer in the shoe during the day, but not so much the spacer or splint at night.
And I don't think we're even carrying those night splints. We might have a small version of it over there, but I think the guys stopped.
Yeah. Yep.
Stopped carrying.
Yep. And I mentioned them in my book because a lot of people ask about them, but yeah, I really don't even recommend them anymore. This is probably hard to see, but this is a surgically corrected bunion. So on the left foot, pretty good angle right here. Basically with surgery, you break the bone, put a couple screws through it. So this is a patient where there's a couple little screws right here holding that straighter. It's nice correction, but it's surgery. So I always tell patients surgery is your last resort. You want to exhaust your conservative options first. And typically, the reason that I'll say, all right, it might be time for surgery is if a patient tells me their lifestyle's affected, like they're doing less things because of the pain, or a patient that says, I don't have any shoes or I'm down to one shoe that I can wear without causing pain. That's when we'll say, okay, might be time to think about surgery. And this patient did well with her surgery. I still see her for other things, but that was a nice correction there. No complications, but there's certainly about a 10 or 15% chance of complications.